Good afternoon. At the outset, I thank Dr. Kumarvel for this opportunity, and it indeed great pleasure to be presenting my topic. The great physicians, I think I spoke to Dr. Shivan, who mentioned both he studied MD in Madurai Medical College, and I think he spoke very high about both of you. I think Dr. Natarajan has completed at least 10 times Harrison Principles of Medicine. So that's what he said to me. So for the next 20 minutes, I think my job is to keep you awake and also to talk about hypocalcemia. So hypocalcemia, we know that calcium is the most abundant mineral in our body. And it is very necessary for a normal skeletal, muscular, hormonal, and neurological function. Almost all function in our body necessitates calcium. We know about calcium channel blockers, calcium channels in the muscles. So almost all of them need calcium for their function. And any value of less than 8.2 is defined as hypocalcemia. And the prevalence of hypocalcemia in both hospitalized and in general thing is variable. I think it varies from around 5% to as high as 70% in study where a critical care patient is present with hyperalbuminemia. So there are two important reasons for hyperalbuminemia, which includes PTH and vitamin D. And other causes of hypercalcemia include the decrease in ionized calcium because of binding of calcium with the vascular space, or a deposition in the tissue, or that can occur with hyperphosphatemia. So my talk, I'll be discussing about basics about calcium metabolism, and also I'll have discuss about few case scenarios which we come across with hypercalcemia, and then few rare but not uncommon cases which I have seen, and also rare cases, congenital cases where we have seen only in books will be discussed here. So the calcium is present predominantly as a crystal structure in the bone. 99% of the calcium is present in the crystal structure. Only 1% of the calcium is exchangeable with the serum calcium. And in the extracellular space, it is equally distributed between intra and extracellular, and approximately 50% of the calcium is bound to the proteins, which is predominantly albumin. So calcium, we know that it is absorbed by two modes. One, by an active mechanism which necessitates the active vitamin D, and another passive mechanism which is also very important when we consume large amount of calcium, particularly older days where they take milk and alkali for GI symptoms, where when the amount of calcium crosses more than 3 to 4 grams, it actually absorbed by a passive mechanism, the paracellular mechanism, where it can cause hypercalcemia. The famous milk alkali syndrome is characterized by hypercalcemia, alkalosis, and renal dysfunction. So the absorption of calcium depends upon a few things. Important thing is vitamin D and acidic pH, which necessitate the dissolution, and also the certain substances which present in our food, like oxalates and phytates, which is commonly present in the legumes and other things, impair the absorption of calcium. So this is the calcium homeostasis. Almost we consume around 500 to 800 milligram of calcium, and the bone, as a means of bone turnover, actually it exchanges around 300 milligram of calcium. So along with an endogenous calcium and then the calcium reabsorbed, the calcium balance is closely managed. So we take around 800 milligram of calcium and we lose around 800 milligram of calcium, predominantly in the feces and also in the kidney. This balance is maintained very closely. So what happens when the calcium goes down? So this is what happens when the minute-to-minute regulation of calcium is done by the PTH. Whenever the slight reduction in the calcium, it actually stimulates the PTH secretion by the calcium sensing receptor, and it acts on the three spaces. One, it converts the vitamin D into active vitamin D that acts on the kidney, where more calcium is reabsorbed and more calcium is dissolved from the calcium phosphate crystals in the bone, and more calcium is absorbed from the intestine by the vitamin D mechanism, which actually regulates the calcium backwards, means in the positive way. So it is a tightly regulated one. Even a small change in calcium is sensed by the calcium sensing receptor, and it is kept within the normal range. So this I've already discussed. I think the physiology of calcium is that even every cell, from muscle, the bone, nerve, and also certain hormones, this hormonal secretion particularly insulin, all depends upon the calcium. If you see, the opening of the calcium channels actually releases the insulin secretion, and it's very important to have a normal calcium level to maintain the adequate body function. The normal calcium, depending upon the lab what you sent. In our lab, it is 10.2 to 8.2 to 10.5, and the ionized calcium is 4.4 to 5, which is exactly half of that one. And it is important to know the corrected calcium value for albumin, because around 50% of the calcium will be circulating with albumin alone. So the daily calcium requirements or the dietary requirement is different in different countries. In India, the ICMR have recommended much lower amount of calcium per day. It ranges from 500 to 1000 from infants to pregnant lady, but the Western recommendations are high, starting from 500 to up to 1300. So that's the reason why in postmenopausal women, we ask them to take 1 tablet of calcium, because our food contains around 300 to 400 milligram of calcium. To have up to 1000 milligram and added 1 more tablet would keep the requirement to around 1 gram per day. So that's the reason postmenopausal women and also pregnant women needs a higher calcium level to maintain their calcium homeostasis. So etiology of hypocalcemia, if you see, it is classified into 2 components. One, low parathyroid hormone level and high parathyroid hormone level. The low parathyroid is very rare, but can happen. Is predominantly congenital, where parathyroid agenesis or destruction, particularly postoperative or infiltrative disease, and reduced parathyroid function, particularly hypomagnesemia. The high parathyroid level, what we see regularly in our clinical practice, is secondary hyperparathyroidism with vitamin D deficiency, and then vitamin D resistant rickets and vitamin D dependent rickets type 1 and type 2, and then the resistant syndromes, drugs, particularly the anticonvulsants, and other important causes which we come as a clinical syndrome like acute pancreatitis, rhabdomyolysis, hungry bone syndrome, and certain cancers. The clinical manifestation vary in both acute and chronic. In acute, we see paresthesia, tetany, seizure, predominantly because of the neurological environment, and also certain signs like Chowstek and Troche's sign, which can be elicited at the bedside to know the calcium status. Chronic, actually different. They have cataract, and then the calcification of brain, brittle nails, all there. And electrographic findings are variable, and the commonest will be prolonged QT interval, sometimes bradycardia and arrhythmia in severe cases. So with this, I move on to few cases which we come across recently. This is a 21-year-old college student as referred by a rheumatologist for evaluation of metabolic bone disease. This patient was treated for basically polyarthralgia and body pain. The patient doesn't show any improvement, even though there is a slight increase in inflammatory markers. He referred here because there is a progression of clinical symptoms like proximal myopathy and then difficulty in walking. So the girl stopped going school because college because she's unable to climb the bus stairs. And the patient have lactose intolerance, and then she avoids milk product and hardly any outdoor activities because of proximal myopathy. So a compound of symptoms have created a vitamin D deficiency. If you see the investigation, hypocalcemia, alkaline phosphatase is elevated, vitamin D is very low, and secondary hyperparathyroidism. So the diagnosis of vitamin D deficiency, osteomalacia, and secondary hyperparathyroidism. So even today, I think we see patients with severe vitamin D deficiency and osteomalacia. So vitamin D deficiency is the most common cause of hypocalcemia, and osteomalacia is not rare. So sometimes we see, particularly in certain religious communities where they use farda and they restrict outdoor activities, and it is common when the 25-hydroxy vitamin D level falls below 12 nanograms per deciliter. So osteomalacia and rickets are similar disease with different manifestations. When it happens in younger individuals before the epiphyseal growth plate is thing, then it can cause skeletal deformity. But it happens in older people, it causes proximal myopathy, and also it can cause weakness of the muscles. So even in sunny India, the vitamin D deficiency is very much common. The prevalence is almost 80%, and this is my thesis where in ambulatory male, even in Vellore, where the summer is there for almost 8 to 9 months, The average vitamin D is only 20 nanograms per deciliter. Almost 80% had vitamin D deficiency of less than 30, and 50% have vitamin D of less than 20. The supplements, I think everyone know now, 60,000 international unit when it is less than 18 years up to 6 weeks, and at more than 18 years can give up to 8 weeks. Obese patient need a higher dosage of vitamin D depending upon the patient. So no need to monitor after giving the vitamin D. And calcium supplement is also important. I think when the representative asked about different forms of calcium, but I think two things are very important. One is calcium carbonate and calcium citrate. When the patient calcium carbonate, it contains around 1250 milligram of calcium carbonate and 500 milligram of elemental calcium, which is less expensive, and it needs acidity for absorption compared to calcium citrate. When the patient is on H2 blockers, then I think calcium citrate can be used, which is called CCM and other thing. This is my second case. This is to know that why the corrected calcium is important. And elderly lady presented with bronchopneumonia on ventilator, referred for hypocalcemia. If you see, the calcium is 7.9, vitamin D is slightly low, creatinine is in the higher limit of normal, albumin is 3. So this patient, I think, is important to know about how calcium is circulated in the thing. As I already mentioned, around 50% of calcium is actually protein bound, 40 to 50%. To have a corrected calcium, this is a formula, total calcium plus 8 into 4 minus albumin. In our patient, it is 1, so 0.4 minus 3 is 1, so it will be around 0.8. The corrected calcium will be not 7.9, it will be 8.6 like that. So it is normal in this situation. So any patients, when they have a low calcium, I think it has to be corrected when the patient is sick to have a corrected calcium value. So this is a takeaway points when the patient is sick. Always check calcium with albumin to know the corrected calcium, and we should understand the physiology of calcium transport, and the pretest probability of vitamin D deficiency is high. Almost 80% of your patient may have vitamin D deficiency. If they are symptomatic, no need to check it, because each cost of vitamin D estimation is around 1,200 rupees, which is 3 times higher than the treatment of vitamin D deficiency. And then we have to calculate the corrected calcium when the patient present with hypoalbuminemia, treat with correct amount of calcium and also vitamin D. So is my, I think, third patient. This is 18-year-old post-operative patient. This patient met around 2 weeks back for a skeletal deformity, and it was evaluated by orthopedic surgeon and referred for hypercalcemia. So this patient, we asked him to wait for a few more weeks to correct the vitamin D and go for surgery, but he's joining a college, so he want to do the surgery at the earliest. So we give a 5 dose of vitamin D, and he's subjected to surgery. A parathyroidectomy was done, and the calcium was 7.2 on the 3rd day, with patient is symptomatic by tingling and numbness. So the bedside examination shows his Chauster-Stein and Troche signs are positive. So this patient have hungry bone syndrome with acute hypercalcemia. Particularly happens when the patient is going for a surgery without correcting the vitamin D and calcium, can lead to this syndrome. This is very rare, no, but this patient accepted that and he went in for surgery because of his personal thing. So how to manage an acute hypercalcemia? When our patient is symptomatic, we should correct with IV calcium. The IV calcium gluconate is most commonly available, and each 10 ml contains 90 milligram of elemental calcium. What we usually do in 500 ml of dextrose normal saline, we add 3 to 5 ampules of calcium gluconate, and we infuse over a period of 4 to 6 hours. And then we check the calcium after 6 hours later, and we tend to maintain the calcium at around 8 to 9 milligrams per deciliter. Another important thing is this has to be followed up with oral calcium carbonate and also active vitamin D, because when the PTH is low, the calcium absorption doesn't happen. To absorb calcium, we need to give active vitamin D in patients who have low PTH level, like this patients. So chronic hypocalcemia is not uncommon. I have a patient who underwent thyroidectomy for dysharmonogenesis, developed permanent hypoparathyroidism, and these patients will be helpful by adding on hydrochlorothiazide, which helps to maintain the calcium at a higher level. Add calcium with a higher dosage, 2 tablets thrice daily, and this patient should be on calcitriol to maintain the calcium. Without calcitriol, the calcium won't get maintained and then it get absorbed. And it is good to give calciferol granules in this patient also, because some amount of the calcium, vitamin D will be converted into active vitamin D, and we have to follow up after 6 to 8 weeks. Another important thing is, don't correct the calcium. We have to under-treat the calcium level to prevent hypercalciuria. These patients, when we correct to normal level, they go for hypercalciuria because of lack of PTH. They come up with the calcinosis of the kidney. The physician, acute hypercalcemia should be treated with IV calcium gluconate, and PTH deficiency is associated with the impaired conversion of vitamin D to active vitamin D. And post-operative hypercalcemia, particularly in a patient who underwent thyroidectomy, takes several days to recover, and sometimes it may be permanent because of the vascular loss. Thiazide diuretics and active vitamin D should be considered in those type of patients for long-term treatment. So this is a clinical case where I was doing my general practice after MD. A patient suddenly come to the clinic with hyperventilation and then breathlessness. She's studying for the exam. All the investigations are normal, and then if you see, the ABG shows respiratory alkalosis with elevated pH and elevated PCO2 of 28 millimoles of Hcg. Calcium is normal, so this is not because of the calcium. This basically, hyperventilation leads to respiratory alkalosis because of lowering of carbon dioxide. This alkalosis causes cerebral vasoconstriction, which leads to the symptoms, and also it dissociates the calcium, which leads to reduced ionized calcium, which causes the neuromuscular excitability. So treatment is not calcium or oxygen. The treatment is symptomatic. Ask them to go for the breathing training. I think they don't suggest to rebreathe in the paper bag. So we used to do that one. They say that when a patient have an organic disease that can aggravate this patient with hypoxia, and when we have 100% sure that this have a hyperventilation syndrome, we can do that one. So this is a 51-year-old patient. This is to highlight that in renal failure, I think hypocalcemia do happen because of the elevated phosphate level, and also vitamin D deficiency, which is mainly because the second hydroxylation of vitamin D happens in the kidney, so that is deficiency of active vitamin D that happens in those type of patients. So when we treat a patient with renal failure, we have to evaluate for the metabolic bone disease and treat this patient with active vitamin D and calcium, not with native vitamin D, because it won't bring down the PTH and don't bring up the calcium level. This patient, along with renal failure, this patient also have a calciphylaxis, which is deposition of calcium in the soft tissue, which is painful in some conditions, or sometimes it may not be painful. Sometimes it can lead to necrosis of the soft tissue, leading to severe pain that needs a local surgical excision of the thing. So the treatment of this patient is symptomatic, active vitamin D, and then treat with phosphate binders to bring down the calcium and phosphate levels. So renal impairment, as I already mentioned, should be treated with active vitamin D and phosphate binders. The other rare causes of hypocalcemia include acute pancreatitis with severe necrosis and saponification, hypomagnesemia in alcoholic patients, drug-induced like phenytoin, massive blood transfusion because of citrate, bisphosphonate and denosumab, oncogenic osteomalacia, vitamin D dependent rickets, neonatal hypercalcemia, particularly in diabetic mothers, and infiltrative disorders such as Wilson's disease and hemochromatosis. So I'll be finishing with 2 slides. One is the congenital hypoparathyroidism. We rarely come across. I have seen only one patient when I was studying in Vellore, which actually is common in pediatric population because we don't see much patients. So most common causes of congenital hyperparathyroidism is DiGeorge syndrome, with a mnemonic of catch-22, which is cardiac disease, thymic aplasia, abnormal faces, and then they have cleft palate, and they also have hypocalcemia. And other syndromes include Kenai-Caffey syndrome, Sanjay-Sakati syndrome, and an autoimmune polyglandular syndrome, and CHARGE syndrome. And finally, I think the pseudo-hypoparathyroidism is fascinating to read this, but we read only in books. And in exam, they ask this question, but we never see these type of patients. And the thing is, it is associated with hypocalcemia, hyperphosphatemia, and Albright hereditary osteodystrophy, which is characterized by short stature, round faces, obesity, short 4th and 5th metacarpals, and then subcutaneous calcification and mild intellectual disability. So hypercalcemia is classified into low PTH and high PTH related. Vitamin D deficiency is the most common in our clinical practice what we come across, and should select appropriate calcium and vitamin D supplements. And then we should know about corrected calcium. Symptomatic hypercalcium should be treated with IV calcium gluconate, and treatment of low PTH hypercalcemia should include active vitamin D. And drugs, I think when we give a long-term like anticonvulsant and other drug, we should look for vitamin D deficiency and treat these patients. Thank you.